Hey everyone, we're going to go ahead and get started today with noon conference. We've got some, we're doing this from the VA, so we've got VA residents in the room who are going to be participating. But just to give them a break, because things are busy over here, feel free to also participate in the chat and throw in any answers, or if you are so brave, to talk out loud. But we're going to do a conference today all about effusions, and we're going to talk through 3 mini cases. So the mini cases are the Gambler, the Rambler, and the Backbiter. So for those of you that are Johnny Cash fans, you will recognize these lyrics. If anyone wants to throw in the chat what song this is from Johnny Cash. Anyone in the room know what song this is by Johnny Cash? No, this is not called the Rambler. So this is actually God's Gonna Cut You Down. So these are lyrics and God's Gonna Cut You Down. So we've got 3 cases about plural effusions titled the Gambler, the Rambler, and the Backbiter. All right, so we're going to start with the Gambler. So our first case, we've got a 75-year-old man with HFrEF due to ischemic cardiomyopathy, EF is 20%, CAD, the STEMI post-PCI, type 2 diabetes, hypertension, CKD. He's coming in with weight gain, worsened dyspnea on exertion, lower extremity swelling. Recently took a 2-week trip to Las Vegas with his wife. He states he was doing so well at the tables that he wasn't able to take his diuretics, Lasix PO 20 daily. He weighs himself every morning and is currently 240 pounds. He's 220 at baseline, so 20 pounds up. Review of systems is negative. His vitals are otherwise stable. He's got JVP to the earlobe, a positive S3, and 2+ pitting lower extremity edema. So for people in the room, what treatment do you think this guy needs? Cool. So you guys have accurately said that this gentleman needs diuresis. For, we'll say interns, because you guys are about halfway through your year, over halfway through the year, how do you decide what type of diuresis and what dose to give this person?
They look at their home dose and then give them the same dosage but IV. So it's technically double.
Cool. Yeah, so Barry says, look at their home dose and then give their home dose IV. So you've essentially doubled their diuretic dose, which is exactly correct. Priscilla says 2.5 times their home dose, which is also correct. So 2 and 2.5 are both acceptable answers here. So Barry and Priscilla, did you base that on any data, or is that just kind of what you've seen or done throughout the year?
What I've seen in the CICU.
Cool. And then Priscilla throws out the dose trial, which is exactly correct. So the first mini teaching point here is on something called the dose trial. So Eric, future cardiologist, and Sean are intimately familiar with this trial. This is a trial from 2011 in which they looked at basically continuous versus intermittent. So continuous versus intermittent. And then they also compared high dose versus low dose diuretics. And so as Barry and Priscilla are both alluding to, there's a dosing strategy that came out of this, which we all sort of now use and teach as gospel. And so what they found in this trial was that there was really no difference in symptoms, but you had better diuresis with the intermittent and high dose strategy. So what is the high dose strategy in the dose trial? And so Priscilla and Barry both alluded to this. So this was basically 2.5x the home dose. And the low dose strategy was the same. So you basically took their PO dose. So this gentleman was on 20 PO daily. You took the IV equivalent of that, which was 10, and you gave him 10. If you were doing the Barry and Priscilla strategy, then you would have given him either 20 IV or 30 IV, and both are excellent. So this gentleman gets IV diuresis, and he starts to improve. So let's talk now about his chest X-ray. So this is his chest X-ray right here. So can I have a brave volunteer? Let's see here actually real quick. Priscilla says, despite the dose trial, I don't often see 2.5x dosing done. Haha. Yeah, I included the haha for effect. Yeah, Priscilla, that's correct. 2x is an easier dose to usually manage and calculate in your head. But 2 or 2.5 is appropriate. I would say myself personally, I do 2 just because I'm less good at math. Okay, so this is the gambler's chest X-ray, goes to Vegas, gets hot at the tables and forgets to take his Lasix or chooses not to take his Lasix. So can I get a second-year resident or an intern to give me their read of this chest X-ray? All right, we'll go with Nemi. You're looking at the screen. I unfortunately have chosen you.
No, that's fair. I would say big things that I guess stand out are looking at the bilateral cost-credit cases, looks like there might be mild bilateral fusions. Don't notice much, again, just like mild acceptalization, but nothing that really stands out, no clear consolidations.
Cool. Yeah, that's a great read. So what Nemi pointed out was loss of the bilateral costophrenic angles and then maybe bilateral pleural effusions. I think this is a really interesting chest x-ray because if you were just going to take a really quick glance at this, you might actually say it's normal or semi-normal unless you looked at the lateral. And the reason for that is this left or right costophrenic angle actually doesn't look that abnormal on the frontal. And the reason for that is because maybe the hemidiaphragm's elevated, but it just doesn't look that weird. But then you look at the lateral image and you can follow the sort of meniscus of that pleural effusion right there. And on the lateral image, it becomes pretty obvious that this gentleman has a moderate to large right-sided pleural effusion from his acute decompensated heart failure. So this right here is the effusion. And then his other costophrenic angle is down here. And you can tell actually that it actually sort of ends right when you get to the cardiac border. And so one of his diaphragms is sitting, his heart's sitting on one of his diaphragms and the other one is elevated because of an effusion. Any questions about this chest x-ray? We will come back to this teaching point in greater detail later. All right, so this gentleman, first one, the gambler goes to Vegas, gets lucky, doesn't take his diuretics. He gets diuresed via the dose trial that Barry and Priscilla have expertly pointed out. And he's diuresed about 25 pounds and discharged home on his baseline goal-directed medical therapy. All right, so we've crossed off the gambler here. Next one, we're gonna go to the Rambler. So, 69-year-old man with NASH cirrhosis. He is complicated by HCC. He's post-TACE a couple years ago, had a microwave ablation a year ago. He has HFpEF, CAD, AFib on warfarin, coming in with confusion, hallucinations. He's rambling in bed and he has dyspnea. Per patient and wife, he had months of worsening confusion, hallucinations, and a change in his speech pattern, which she described as him being more talkative. Has 1 to 2 weeks of worsening dyspnea on exertion, cough, and he has a more acute worsening of his mental status during that time period, and his vitals are notable for fever. He's very talkative, but he's otherwise in no acute distress. So first question for this gentleman is we're going to show his chest x-ray to really hammer home these teaching points here. So here's the Rambler's chest x-ray. So Nemi is already out of the loop because he just read the last one. So can I get another intern to read this strikingly similar chest x-ray? Nice. So Colleen also expertly points out that this gentleman also has a moderate to large right-sided pleural effusion. And so this one's a little bit more obvious because on the the front view, you can see this meniscus here. And then on the lateral view, again, you can see the meniscus again there. So a little bit more obvious than the last one, but just a good sort of repetitive teaching point about how to recognize pleural effusions. Can anyone else give me another sign on this chest x-ray? Let's say you didn't know anything about this gentleman's presenting history, other piece of evidence that he may have cirrhosis or liver dysfunction. Oh, Dr. Chan, a step ahead. So Dr. Chan expertly points out that he also has gynecomastia as well, and then the gynecomastia may be contributing to that, the appearance of the right side as well. So the gynecomastia, so if you didn't know anything about this gentleman's history, you may think that he has liver dysfunction or cirrhosis before you even see him. Okay. Dr. Chan, any additional teaching points on this chest x-ray? No. Cool. All right. So why do you guys think this person's confused? How would you approach confusion in a cirrhotic patient? Okay, great. So look for asterixis on exam. I'll tell you that he has no asterixis. Yeah, great question. So history of hepatic encephalopathy. He does have a history of hepatic encephalopathy. He is compliant with his lactulose and rifaximin. And then Cassandra points out, she thinks about infection, lights, and GI bleed. So, right, so triggers for HE. So infection, lights, and GI bleed. Perfect. So you guys are going down the hepatic encephalopathy pathway, which is awesome. What else would you include on your differential for encephalopathy in the elderly? Yeah, so Elizabeth asks, is it more of like a hyperactive delirium or is he just talkative? And it's more of a hyperactive delirium state. Cool. Sandra goes with maybe structural if he's got some sort of mets to the brain from his cancer. And meds. Cool. I think that's a pretty good place to start. So big causes. So hepatic encephalopathy. We know he has cirrhosis. Does he have a brain met with his known HCC, or is he taking any medications and remembering like our Beers criteria? So let me give you guys a med list. So this is this gentleman's med list right here. I'll give you about 15 seconds to look over the med list and then give me your thoughts. We'll take any thoughts on this med list. All right, any medicines that stand out which may be contributing to his hepatic encephalopathy? While you guys are thinking about that, Dr. Chan also pointed out that urine retention, cyst cerebral syndrome, and uremia, which I have never heard of before. So Dr. Chan, if you could put a little bit more in the chat about that, that would be appreciated. So what do you guys think? Medicines on this list that may be contributing to encephalopathy or delirium in this gentleman?
There's not a lot there. There's like potentially some volume status change that could happen. Morbidity is the only one that like can have some mental status change. But these can contribute to metabolic change, but we're just dealing with that directly.
Okay.
Oh, it, yeah, good point.
Cool. So DIG, so recent DIG level, great. So you guys hit on it. So this med list is not, like not that abnormal, but there are a couple big offenders, the biggest being DIG. So you do an expert review in the JLV, the Joint Legacy Viewer here at the VA, and you find out that his DIG level about 2 months ago was 0.9. So therapeutic is 0.3 to 0.8, and his presenting DIG level is 1.3. So he has supra-therapeutic digoxin level, and you do a little bit more reading and you think to yourself, maybe this is digoxin toxicity. What symptoms would you expect besides delirium if this guy has digoxin toxicity? Say it loud. Cool, so we're thinking maybe eye things. Oh, sorry. Cool, so eye things, EKG changes. You can see delirium, so CNS stuff, and then the very last thing is you can get sort of like GI stuff. So nice job. So you guys like correctly identify basically all the components of digoxin toxicity. The eye thing is classically called xanthopsia, so it's like yellow-green color vision. And so this has been implicated in some of like maybe Van Gogh conspiracy theories that maybe Van Gogh had digoxin toxicity from taking like the digitalis plant, and that's what his yellow period is from. And then the EKG changes, you basically get this thing that looks like a reverse check mark, and so you sort of get a slope like that, and that is the DIG artifact. So this gentleman has, and then Dr. Chan says chronically they can sort of wither away, which is sort of what we thought might have been going on with this gentleman. So you stop his digoxin, but he still is confused as his DIG level comes down. So we'll scroll back up to his chest X right here. Anything else you would like to do to further work up encephalopathy in this gentleman? Cool. Priscilla, diagnostic para, you'll get that as well. You've got your needles out. Where else would you maybe want to put a needle? Great. So Cassandra says he was febrile, so tap all the fluid pockets. Great. So this gentleman gets a thora and a para. So let's go down and show his para, his thora. So this was a VA thora that I did last year. So this is what comes out of this gentleman's body. Any thoughts from people in the room? Does this look normal or abnormal compared to your usual pleural fluid? All right, we got AB normal pleural fluid. And if you were going to describe this before it got to the lab, how would you describe it? Great, it's bloody. One other big defining characteristic here. Yeah, so it's kind of like cloudy or milky. Perfect. So as Sean points out, you should be able to see the table through your pleural fluid. It should be relatively clear, and you cannot see anything through this pleural fluid. So you can't see the other side of the syringe. You can't see the thing it's sitting on. So it's a bloody and cloudy, milky pleural fluid. So this is what his labs looks like. This is another VA report. So take about 30 seconds and look at those thora labs. And then while you're doing that, I will write down the other labs that you have asked your attending to grab. So these are all pleural fluid labs. And then in parentheses will be the serum lab. All right, and then, so can I get an intern to give me their impression of the pleural fluid labs? So there's some silence in the room, which is actually the right answer. So we talk all the time about paracentesis fluid and multiplying, get to see how many PMNs we have, but we rarely ever talk about looking at pleural fluid for our cell counts. That's sort of a thing that we don't often consider. But this gentleman does have an elevated white blood cell count. He's got an elevated RBC count, which is not surprising, and it's mostly segs predominant. All right, so we'll talk about what to do with these labs in just a second, but is there any additional lab that you would want to get based on the cloudy, milky appearance? Triglycerides, perfect. And Trey, why are you getting triglycerides?
Looking to see if there's like lymphatic obstruction.
Great, so looking to see if there's maybe lymphatic involvement, or you're looking specifically for a diagnosis called chylothorax. So this gentleman has a triglyceride level of 213. 213 is very high. So anything greater than 100 is diagnostic of a chylothorax. So this gentleman has a chylothorax, but he also has another process going on. And that other process is directly related to his white blood cell count. So this gentleman has something called an SBEM, or spontaneous bacterial empyema, or spontaneous bacterial pleuritis, or SBP. So what is that diagnosis? Has anyone heard about this, treated this, seen this? I know Dr. Chan has. I think Dr. Chan was the consult physician last year when this person came in. But essentially, so what this is, I'm going to pull up a clip out here of the lungs to explain this. So chylothorax is basically SBP, spontaneous bacterial empyema is basically SBP of the chest. So, right, you can get secondarily infected ascites, spontaneous bacterial peritonitis, and you can get secondarily infected hepatic hydrothorax. So if you have a hepatic hydrothorax and that gets secondarily infected, via bacteria coming up through the diaphragm or via translocation from a bloodstream infection or a pneumonia or something like that, you get something called spontaneous bacterial empyema or spontaneous bacterial pleuritis. So this happens to about 20% of people with hepatic hydrothorax. So having hepatic hydrothorax, if they come in with fevers and stuff, you should probably still do your thoracentesis to rule this process out. So if you know he has hepatic hydrothorax, you know then he's got spontaneous bacterial empyema, which we diagnose very similar to SBP. So greater than 250 PMNs in the thora, or greater than 500 with a negative culture. You've made your diagnosis. So if you've made this diagnosis, how do you treat it? All right, so Kate says ceftriaxone. She's taking the easy road out here, which is give him antibiotics, which is absolutely correct. So you definitely give ceftriaxone. Anything else you want to do? Great, so Anita says chest tube, the room says chest tube. That was a trick question. You have just made this gentleman exponentially worse. So the one thing you don't do is a chest tube. And that is the teaching point here. So you don't do chest tubes for chylothorax and you don't do chest tubes for hepatic hydrothorax or spontaneous bacterial empyema. Does anyone know why? Yeah, great. So this is never going to stop draining. And so essentially, it's the reason we don't put indwelling tubes into people who have SBP or have ascites, because they'll basically become nutrient deficient very quickly, because they'll basically keep draining from that chest tube because you haven't done any of the underlying things to stop the cirrhosis or the process which is causing the fluid to show up there. So functionally, you should just treat this exactly like SBP. There is very limited data on this, but what I did find is you should treat with ceftriaxone and you should also treat with your albumin dosing, just like you were treating for SBP. So giving them that 1.5 grams per kilogram on day 1 and then 1 gram per kilogram on day 3.
Is there any benefit to like draining it, like you drain that one time, then all the way out?
Yeah, good question. Sean asks, is there any benefit to draining it once? And no.
Just like if you're having this sinus infection, like it just in my head doesn't make a lot of sense to keep giving pumping antibiotics through that.
Yeah, good question. So this gentleman had a transitive effusion. His cultures were negative, so he didn't have a true empyema. The name is misleading, so you don't have to drain it once. You basically just treat through it exactly like you do for SBP. And you don't put a chest tube in because they will get markedly worse. Dr. Chan, do you have any more thoughts on spontaneous bacterial empyema or pleuritis? Give Dr. Chan a second to try to talk here.
Not really. Did he get a peritoneal tap too?
Yeah, he did. So his peritoneal tap at the same time had less white cells than his chest. And so we presumed that it started in the chest and then either migrated down, but it didn't seem like it was secondary to the SBP. All right, and then Cassandra brings up the last teaching point here, which is how on earth do we treat chylothorax? So 2 separate problems in this guy. So chylothorax, you want to put them on basically like this weird mineral oil and like high chain diet. It makes no sense to me, but there's a special diet that you put them on. And the reason you do that is you want to decrease essentially like lipid production. And then you want to treat the underlying cause. So whether it's cancer obstructing the thoracic duct or an infection causing inflammation or all their lymphatics are engorged because they're volume overloaded, you treat the underlying cause. And again, you do not put a chest tube in these people unless it's for sort of late term palliation.
Just typically in terms of the side of the chylothorax, typically when it's right side, so chyle begins in the in the lumbar region, like this chyla cisterna or something like that, on the right side, and then and it goes up the vertebral column, and then at some point it crosses to the left side and then drains into and becomes a thoracic duct, right? Typically, the way I remember is that if there's obstruction before it crosses, typically the chylothorax is on the right side, and if there's obstruction after the chyle duct crosses, then it's typically on the left side. So if there's any obstruction, I would think that it would be somewhere in the abdomen somewhere rather than in the chest. And as you said, you treat the underlying problem, but sometimes octreotide can help decrease chyle formation too, I think.
Awesome. Yeah, great point. So I actually completely forgot about that one. So octreotide as well. you splanchnic vasoconstrict, and you can hopefully decrease chyle production as well. So octreotide and then a very special type of diet. If you do this at Denver Health or at the VA, talk to your dietitian and they will give people a very well written out summary of what you can and can't eat. Basically, you can't eat anything that tastes good. That's like a good rule of thumb because all of it has fat in it. All right, so 2 cases down. So just as a reminder, we talked about the dose trial and how to diurese off a pleural effusion. We then talked about spontaneous bacterial empyema or pleuritis, which is going to be, it's a misnomer in the name. It's not really an empyema. It's essentially SBP of the chest, and how you should treat with ceftriaxone and albumin and basically pretend that it's a peritonitis. And now we've got our very last case, which is the backbiter. So for those that came in late, we're like cycling through a single line of a Johnny Cash song here called God's Gonna Cut You Down. So the gambler was a guy in Vegas who stopped taking his diuretics. The Rambler had digoxin toxicity, and the backbiter is a gentleman who was just discharged from a surgical service. All right, so you've got a 68-year-old man who had a squamous cell cancer post-right pneumonectomy about 2 months prior. He's coming to the ED with 3 days of fevers, rigors, and dyspnea. So let's get right to his chest x-ray here. So I'll give you guys about 30 seconds to take a look at this. You've got your frontal view on the left, your lateral view on the right, and then give me your, I'll ask for a volunteer to give me their focused read. Remember that he has had a right pneumonectomy. All right, any volunteers to read this x-ray? Dr. Shan, his pneumonectomy was a month and a half prior to presentation, so 6 weeks prior. Kate, give me your focused read that you're seeing here. He did. His whole right lung is gone.
I don't see any lung on the right.
The whole, yeah, you do not see lung on the right. Great. Strong start. We got no lung on the right.
Pretty clear fluid level. Can see diaphragm on both sides, I believe though. Kind of looks like he has like gas, like smaller levels. I don't see the diagram to me.
Great. So Kate says she sees no lung on the right, which is correct. She sees a very straight air fluid level, and then she sees no diaphragm and maybe these gas bubbles above the diaphragm, which is excellent. That's a perfect read. So when you have no lung there and you have an air fluid level, you see a straight line. And the reason for that is like pretend you're like imaging a chest, like a graduated cylinder or like a beaker or something. The fluid will just layer flat. Like you're imaging a space that has a flat line fluid in it. And then these fluid bubbles right here are also, per the official read, they were concerned that this meant there was gas inside the chest or some sort of gas forming organism, but they couldn't rule out that being bowel that had just risen up. So there was some concern that this was either a gas forming infection or something else. So what do you guys want to do for this guy? CT, great. CT is obtained and it shows a hydropneumothorax. And it doesn't get you any closer to answering the question of whether it's infected. Tap it. I love it, Barry. So Barry says, let's tap it. So you are finding the theme of this conference. So you perform a thora and grossly purulent fluid comes out. And within basically an hour, you have GPCs growing in the lab. So what is this gentleman's diagnosis? This one's not a trick. It's not a misnomer. There you go. This is Everyone was gun shy after something was called an empyema and wasn't an empyema. This is just an empyema. So this gentleman is an empyema. He has a post-surgical, post-pneumonectomy empyema. You just did a thora. You found this. What do we need to do next? We have not. So he gets antibiotics. Perfect. Yeah, this guy needs a chest tube. So this is the right person to put a chest tube in. So you call either pulmonary or surgery, and they come by and they put a chest tube in, and he actually gets transferred to the surgical service because he is post-op, and this is a presumably complication of what he just came in with. So this gentleman has a post-pneumonectomy empyema. When he gets the chest tube placed, he has a continuous air leak, which makes the surgical team very suspicious for some underlying pathology in the lung. And so he eventually goes to the operating room for a procedure. They are looking to hopefully definitively fix this, and I'll just put up the op note here, give you guys a chance to read it while I highlight some pertinent stuff. So they create a 10 millimeter port, 7th intercostal space. They explore the chest, they visualize the hilum, and there's some bubbling coming from the area of the bronchus. Given the likelihood of a BPF, so a bronchopleural fistula, and need for definitive management, I determined an LOSer was the best course of action. Talk about what that is. It was okayed, and then they went ahead and proceeded with an LOSer. So they resected ribs 4 through 6, create a large pleural window, and then pack the chest and debride. So I actually was not familiar with an LOSer flap or procedure until about 1.5 years ago. Has anyone seen one of these before or heard about this procedure? Barry, what is it?
Over the front of the ribs, and then they kind of go to the curls. It's never really
Yeah, so something weird happens and the person gets a procedure. And is there a flap? Like, what's going on? So this is the Backbiter X-Rays here. So take about 30 seconds and point out what the glaring abnormality is on the frontal image. Great, so everything, the trachea is shifted, so you've got volume loss on that side, awesome. Yeah, there is like, he is missing critical parts of his chest wall right there. Cool, so this gentleman is missing ribs, and it appears that he has a hole in his chest. So just to prove to you guys that that is actually an LOSer procedure, just so you can all say you've seen it, here is a video of his CT post-procedure. Normal, abnormal. So play this one more time, and I've got the lung windows as well for those that are interested. So you can see the surgical clips right there where his bronchus is cut off, and then right there is a hole in that gentleman's chest wall where his rib should be. So what does this look like on a lung window? So that stuff right there on the left is packing, or sorry, on the right is surgical packing that's been inserted into his chest. So play that one more time. So that gentleman has no right lung. He has surgical packing where his alveoli used to be, and he is left with a very, very open chest wall. So this gentleman underwent something called an LOSer flap, which is a surgery that we often don't see anymore for some very, very good reasons. So LOSer flap, and if you guys were going to take a guess about possible complications of having this flap, what would you guess?
Death.
Death, okay, great. Yeah, death is like extreme, but infection, great. You've got an open pleural space. And then similar to the SBEM pleuritis guy, malnutrition, right? You've got this huge hole in your chest, which means that you're often chronically ill and very sick at baseline, and you're at risk of losing nutrients and vitamins. Okay, so LOSer flap. So what exactly is it? So this is a picture from a 1935 medical textbook by the guy who actually invented the procedure. His name was, I think his name was like Eli LOS or Leo LOS or something like that. But essentially, the reason we initially did this flap was for TB empyema. So before we had any sort of treatment for TB, this guy thought that cutting a hole in someone's chest and letting it naturally drain gave them the best chance of cure. So he pioneered this procedure for the first time at SF General back in the 1930s. And I think the funniest part about this article, which is like basically mocking him in the 80s, is there's this specific paragraph, which was too good not to include. So he promised in his initial case report, he only wrote 2 case reports on the LOSer procedure. He promised in his initial report that he would eventually give details with x-rays, case histories, and other data that he would soon publish. Unfortunately, other matters diverted my attention from gleaning these details and statistics. So he just never published any data on his own procedure. And his initial report was apparently so inexplicable and hard to follow that it was like a word of mouth procedure for the next 40 to 50 years, where if you trained at SF General, you knew how to do it, and everyone else was sort of just listening through the grapevine for procedure details. So what does it actually look like in real life? This is an image from a more current picture. So essentially you make this incision in the person's chest, you take out ribs, you create a skin flap, which you then suture down, and you essentially create an opening in the pleural space. If they have no lung left, you pack it to make sure that it doesn't become a potential space for infection. If they do have lung left, your hope is that the lung will expand to approximate the pleural surface and close it off. It sounds like that almost never happens. But this is sort of the goal of it, is to let a chronic empyema drain from the pleural space. Right now, the only 2 reasons we still do this really are this gentleman's indication. So if you have a bronchopleural fistula, post-pneumonectomy, so very specific. And then if you have a chronic empyema, and even then it's sort of way down the line of potential treatments. But those might be 2 reasons why you'll see a person with an LOSer flap. Realistically, these people can't usually live at home by themselves because they have so many issues with having a chest that has a hole in it. So these people end up in LTACs, skilled nursing facilities, and places where they don't necessarily thrive. Dr. Chan, do you have any additional thoughts, teaching points on the LOSer flap?
Yeah, I think they put those packing that you showed on the CT scan. It just basically has to be done on a daily basis. I think they use Gergen solution, which is, I can't remember what it is, but I keep wanting to think that it's some kind of a bleach solution or something, just to sterilize that area.
Yeah, and in the initial report, apparently the LOSer gentleman who created it complained that his nurses were too sterile in changing the dressings and that you should change as little as possible. So interesting guy. This procedure isn't done very much anymore, and it is associated with pretty poor outcomes. But in a nice turn of events, the gentleman who got this procedure actually did pretty well and had it closed about 3 weeks ago with a serratus muscle flap and was discharged home. So he had sort of the best possible outcome for the LOSer procedure. So what did we talk about today? We talked about the Gambler. Sorry, say again.
Missing some ribs.
Oh yeah, he's still missing ribs, and he's still doesn't have a right lung, but at least he doesn't have a hole in his chest. So the Gambler, gentleman who got lucky at the tables and stopped taking diuretics. The Rambler, digoxin toxicity and spontaneous bacterial empyema from superinfection of his hepatic hydrothorax. And the Backbiter, a gentleman who ended up with a hole in his chest because of a post-pneumonectomy bronchopleural fistula and empyema. That's all I got. Any additional questions?